Good afternoon, or it is just 2 minutes past 12 in Malawi, and I welcome you to the warm heart of Africa, which is in the southern Africa. Malawi is a small country. The surface area just over 118,000 square kilometers, 20% of which is the lake. It is regarded as a high TB HIV country because the HIV is quite high, although TB figures are quite low. The World Health Organization estimates that out of the cases that we notify annually, we miss 50% of them. Actually, a survey that was carried out about 10 years ago, a previous survey showed that indeed we are missing close to that. And in addition, we also found out that the urban population, the prisons, and other vulnerable groups, the groups that are very vulnerable to TB. And therefore, we decided as a country to put into the routine screening for TB, modern methods such as the digital X-rays, the gene expert, and we are expanding slowly to cover the whole country. Therefore, mobile diagnostic digital X-rays and gene expert, which are the newer methods, are the ones that we are using. The survey also showed that there is poor seeking behavior among Malawians. As I've pointed out, it showed that the survey showed that 36% of those people who were sick had never presented to any hospital, and another 30% had gone to hospital, but our health system could not catch them. And therefore, we, having realized that there's need for active TB case finding, we approached WHO, who recommended that the Global Fund should assist us in procuring mobile X-rays to go into communities, especially the vulnerable. Next slide, please. And therefore, we managed to procure 7 mobile digital X-rays. Our cover slide, you saw 7 of them being prepared for a field trip. And they were equipped with Gene Expert and easy digital radiography machines. We configured them with card for TB to assist our health workers to make a diagnosis. You should know that these are put in a routine situation where we're not sending specialists there, but we are sending the frontline health personnel whose X-ray interpretation may not be that good. So we were using symptomatic screening by asking the 4 cardinal questions of a cough, a fever, night sweat, and loss of weight. And then every one of them went to that mobile van and went chest X-ray picture. Unfortunately, or fortunately, we were only using adults, and children below the age of 15 were not part of this screening apart from the symptomatic. This is because we are following what our survey told us. We are now concentrating in high risk and vulnerable populations. Therefore, we are targeting prison inmates, refugee camps, industrial areas where a lot of dust and unfair practices happen, ex-minors and minors, as well as healthcare workers. Of late, we have had the internally displaced people in the flood-prone areas, and these are usually aggregated in the camps, and these also have been targeted. We start by providing intensified community awareness. So a team goes to wherever we want to go a week in advance to mobilize the people, to register the people, and to actually book them to go to the mobile van. Next slide, please. And the vehicles arrived early in the year 2018, and actually March 2018, that's when we started the screening processes. So as a result, what has happened as of today, or as of December 2021, over 395,000 individuals have gone through the screening process. And they were composed of 220 males and 175 females. And through our screening purposes, processes of using chest X-ray and symptomatic screening, we managed to identify 53,638 as presumptive TB cases. And using gene experts and the X-rays, 3,705 were diagnosed as TB patients, and they have gone through treatment. This translates to 955 cases per 100,000. This is way too high. The previous survey showed us to be around 400 or just about less than 400 per 100,000. But our screening showed this high figure. Next slide, please. And so just as we went through the routine, we thought we should be tweaking these figures. And so the next set of slides that I'm going to show you here, we are tweaking those figures to find out what's happening, because these people are working in routine conditions, and therefore a lot can happen. So since we started up to now, you will notice that in the beginning we had very high numbers of presumptive TB cases, the blue bars. And we were wondering, is it true that we are seeing all these as presumptives, especially that the cases that are coming out are small? So the orange bars are showing the TB cases. And you will also notice that from around Q4 of 2020, there is a reduction of almost half of the presumptives as well as of the cases. Well, this we can attribute to the restrictions that are happening when there is high incidences of COVID-19. Next slide, please. So when we take the cases and again look at them, as I pointed out, you'll find we find quite a lot of cases earlier in the beginning, of the screening. We had very small numbers, and then suddenly from Q1 of 2019, the figures began to climb to a maximum of around 430 in Q2 of 2020. And then suddenly Q4, they have gone down. We should point out that when we saw this, we were a little bit concerned that we should be seeing 995 per 100,000. So when we tweaked them, we find that the majority of these cases are actually diagnosed using the X-ray rather than using the gene expert. Next slide, please. So this is the slide that shows that the blue bars are those that are diagnosed through gene expert, and the orange bars are the ones that are diagnosed using the chest X-ray. This is a combination of the card for TB as well as the clinician's own determination of the X-ray. And so we then decided to put an intervention, especially from Q4, to train them on X-ray interpretation, and also to tell them that the X-ray images in the presence of COVID-19 could be misinterpreted as TB. And therefore, after that training, that's when you see the blue bars are going up and the orange bars are actually reducing. And indeed, the decrease in the cases are happening while the cases that are diagnosed through gene experts are increasing. And so we have determined that we need to train our clinicians in X-ray interpretation, as well as also to make sure that the diagnosis, especially that we are going into the community where we are screening most of the time people who are not sick, they should interpret the X-rays with care. And we should also point out that we have moved from the areas that we concentrated on. These are the urban areas. to areas of less density in population, as well as where routine figures don't show that TB is as high as in the urban areas. Next slide. Okay, so this linear graph is just to interpret what has happened as the numbers of TB patients diagnosed through chest X-ray are reducing. You will notice that the percentage in terms of gene expert is picking up. In other words, the gene expert is not reducing as well, but it's only those that are diagnosed through chest X-ray. Next slide, please. So this is just some of the interpretations and some of the findings that we are noting as we go through these figures in the 7 mobile vans. Of course, there have been challenges as we use the mobile vans. The first one being that the implementation in the beginning was actually coupled with the high proportion of presumptive TBs. And this is when the card for TB score was very low at 40. So we, the clinicians were having a lot of people taken as the presumptives. However, this did not increase on the cases, and therefore we requested that we should put the score to around 50 and then to 60. And hence, some of those cases among the clinically diagnosed have reduced. There has also been high staff turnover. In other words, most of the staff that we started with have moved on to greener pastures and left the screening of the people. And this means that we have to continue recruiting new ones and orient and train them in the use of these mobile vans. We have also had the inadequate local capacity to maintain the vehicles as well as the X-ray machines and the solar power systems, because these were imported from, were imported by Delft. So we have to rely on Delft to come now and again. So sometimes to make arrangements, some of the vehicles, 1 or 2, could be off the screening schedules, and that this also delays the screening of the community. The effects of COVID-19 cannot be overemphasized, as there are restrictions in the movement and gatherings of people. So even the mobile vans were somehow affected by the COVID-19 restrictions. Next slide, please. As the way forward, what do we do now that we have now established a routine of screening the community and finding the cases in the community? We think that, of course, as I pointed out, we moved into the 4 urban areas and 1 district, which had very high burden of TB. Now we have moved to the rest of the country, and at the demand of the district health officers, we go to various areas to do the screening. Of course, we need to ensure that we keep targeting the vulnerable communities, such as prisons and mining companies, refugee camps, as mentioned earlier. We have to respond, as I pointed out, to the district health management teams to do screening in certain populations that they feel need an emergency screening, and we have to respond to that. Sometimes that also has a bearing on our routine screening. And next is we would like to use our mobile vans to carry out prevalence surveys. Usually we carry out what are called national prevalence surveys, but we also would like to carry local level or district level prevalence survey. This will assist us in, again, finding which districts have higher TB, although routine data shows that it's the urban areas, but some districts could have also high data. So this is how we want to move in the future. Next slide, please. Okay, in conclusion, and the lessons that we have learned, we think that active TB screening using the mobile vans in priority areas needs more resources in order to find the missing cases. And that card for TB is important because it also works well with our mobile, local staff who may not be experts at interpretation of chest X-rays. We are going to continue targeting screening at the levels of implementation to improve the yield. And this will be done by, pointed out, targeting high risk and vulnerable populations. And finally, these results have indicated the significance of continuous capacity building and job mentorship, as you pointed out, that most of them are coming in and out in order to improve the yields and the quality of service. Thank you very much for listening. This is the end of my presentation.